Okay, hi everyone. Thanks so much for joining. My name is Christina Chant. I work at the BC Centre on Substance Use as the Director of Education and Clinical Activities, and I'm really grateful to be moderating today for this session that's focused on rural and remote considerations with our new guideline for the clinical management of opioid use disorders. And so just to get us started in a good way, I'll start us off with a land acknowledgement. And so I just first want to acknowledge that I'm gratefully calling in from the unceded traditional and stolen territories of the Musqueam, Squamish, and Tsleil-Waututh Nations, and I have immense gratitude for these lands. And then as the BCCSU, a lot of our work in our office also takes place on the unceded homelands of the Coast Salish people. And but we also recognize that our work and we work in partnership with many people and many nations across the province. And we recognize that the ongoing criminalization, institutionalization, and discrimination against people who use drugs disproportionately harms Indigenous people, and that continuous efforts are needed to dismantle colonial systems of oppression. So we see our work as deeply connected to these efforts, and we're very committed to contributing to a system of care that provides safe, respectful, and evidence-based care. So I'm going to just do some brief introductions. We're very grateful for having an excellent panel today. We have with us Dr. Paxton Bach, RPN Karen Fulton, and peer advisor Jenny McDougall on our panel today. And we also have immense gratitude towards our medical writing team who have supported in crafting this work, and our team members from the education team as well, who are helping basically organize and have us present to you in a good way today. Okay, then just a couple of things that we wanted to talk about before we get going. It's just that there will be a pre and post webinar poll. And this is also a Zoom webinar, so you'll expect that the participant pieces are, or you're not able to speak, but you can ask questions in the Q&A box on the Zoom. You can vote up questions that you have. We have dedicated time in this presentation today to go through some of the questions, and if there are some burning questions at the end, sometimes we're also able to follow up via email with those questions. And I think that might be it from me, other than what is in notes in the slide here, but you'll hear from me a bit later on in the chat. So we'll just give you a little bit of time to complete the survey. And I will just note too that it's really valuable to us for you to answer, do the pre and post evaluations. This helps us do a better job in the future. Particularly, we are interested with our rural remote partners in different regions, how this lands with you and how we can provide future education. So we really do appreciate your time in answering those. Give you just one more minute and then we'll get started. Okay, so I'll hand it over to the panel to get us started, and thank you so much for joining us today.
Hello, I'm Karen Fulton. I'm a registered psychiatric nurse, and I work in the capacity of an OAT nurse prescriber out of Princeton and Kirmias. So today I'm meeting on the traditional, ancestral, and unceded territories of the Silks people. The learning objectives today, by the end of the session, you should be able to apply the key recommendations in a guideline for the clinical management of opioid use disorder in the context of rural and remote settings, apply recommended principles of care when treating opioid use disorder, apply strategies to prevent and manage precipitated withdrawal during a buprenorphine naloxone induction, apply updated dosing, titration, and missed dose protocols to buprenorphine naloxone, extended release buprenorphine, methadone, and slow release oral morphine prescribing, and apply updated take-home dose clinical guidance for buprenorphine naloxone, methadone, and slow release oral morphine prescribing. In 2017, the BC-CSU released BC's first provincial guideline for the treatment of opioid use disorder, referred to as OUD for the remainder of this presentation when I'm speaking anyways. When it was released, it was the first of its kind to recommend buprenorphine naloxone as a first-line opioid agonist treatment, or OAT for OUD. Recommend slow-release oral morphine as an alternative treatment option for OUD, and include harm reduction services as a standard of care. The updates we are presenting today recognize new evidence and clinical practice changes and aim to meet the evolving challenges that have resulted from unregulated fentanyl and other toxic substances such as high opioid tolerance. Since 2016, when a public health emergency was declared in BC, to 2022, at least 9,760 British Columbians have died from opioid toxicity. Although every part of Canada has been impacted by the opioid crisis, BC has seen both the highest number and the highest rate, with 45.3 persons out of 100,000 in 2022 of unregulated toxic drug deaths. Within BC, Northern Health Authority had the highest rate at 58 persons per 100,000, while Fraser Health Authority had the highest number of toxic drug deaths at 236 deaths in 2022.
We're going to take this time to do a moment of silence in recognition of these are not just stats, but these are our loved ones, our children, and our friends. So we'll take this time to take a moment of silence right now. Thank you so much.
Fentanyl was detected in approximately 86% of overdose deaths in 2021 and 81% of toxic drug deaths in 2022, which represents substantial increases from 2012, when 3% of the deaths involved fentanyl. An investigation of whether drug-related deaths between 2015 and 2017 involved prescribed or non-prescribed medications revealed that 83% of deaths involved non-prescribed opioids, with fentanyl or its analogs being the most prevalent type of opioid detected, found in 79% of deaths related to non-prescribed opioids. The prevalence of fentanyl in the unregulated drug supply has led to increased opioid tolerance, and it will be reflected in the guideline update. Before moving on to reviewing the key updates in the new guideline, the next couple of slides briefly describe the challenges faced by rural and remote communities, so that as we move forward, we can think about how the new guidelines address these challenges. Approximately 14% of British Columbians live in rural areas. 30.3% of Indigenous people in BC live in rural areas, and another 40.1% of Indigenous people live on reserve. There is a lack of recent data on rates of OUD in rural and remote BC, but we know that people in rural British Columbia, especially rural Indigenous people, experience a higher burden of illness and lower life expectancy. Individuals who live in rural and remote communities are more likely to be undiagnosed and untreated for substance use disorders, and more likely to report unmet substance use care needs. This is due to a lack of factors, including lack of treatment services and general health resources, shortage of care providers with training to provide substance use disorder care, such as OAT, long travel times with limited transportation options, and the impact of weather, and work commitments may differ depending on local industry and stigma. Next slide. Several strategies have been identified for providing effective OUD care to patients in rural and remote settings. Flexibility with take-home dosing, which is considered in situations where daily visits to pharmacy are not feasible due to the distance or other limitations. Engagement of nurses can play a key role in increasing access to and retention in OUD care in rural and remote settings, as they are often the primary care providers in these communities. Collaboration and rapport are provided through frequent check-ins, through text messaging, phone calls, or outreach. RN and RPNs who complete certified practice requirements are able to prescribe OAT. Wider adoption of virtual care, often called telehealth, enables providers to consult with patients from a distance, eliminating the need for and additional costs of patients' travel to other communities. Clinicians build relationships with community and community partners outside of providing care for OUD. This includes building rapport and connection with vulnerable persons, people who use drugs, and community partners such as nonprofit organizations, pharmacy, Indigenous partners, and interdisciplinary team members by providing education, raising awareness, providing harm reduction, collaboration, and providing wound care. Care may also need to be provided outside of a clinic to meet people where they're at. Clinicians provide care in clients' homes, shelters, community centers, roadsides, parks, or alleyways. Care providers can determine how to adapt the recommendations in this guideline in order to reduce barriers for patients. All adaptations to the recommendations should have a clear rationale, take patient and community safety in consideration, and be documented.
Can I just add quickly to that slide? Just a quick sentence. One of the things that we are doing in Quesnel is I'm up here and I'm also a long-term methadone client at our clinic. So the doctor has let me deliver the OAT and the safe supply meds to our community members. I've been doing that for 3 years and we have had huge success with it, with people maintaining and getting to a good dose. None of the people that are on this program are overdosing anymore, and they used to overdose all the time.
That's great, Jenny. So the new 2023 update will show us updated clinical recommendations and guidance on the full continuum of care for opioid use disorder based on new evidence and clinical practice changes, comprehensive principles of care, updated protocols for dosing and titration, missed doses and take-home dosing, and considerations for providing care to specific populations. And next slide. So principles of care. The updated guideline features several overarching principles of care to facilitate collaborative partnerships with individuals and families experiencing opioid-related harms. So the principles of care include patient-centered care. Clinicians should strive to provide care that is respectful of the unique needs, values, and preferences of each person. Individuals should be empowered as experts in their own care. Patient-centered care includes providing access to services and treatments without undue barriers. Commonly reported barriers to OUD treatment include lack of control or flexibility with treatment and difficulty with access. Care teams should strive to access a patient's needs and ability to access treatment and facilitate low barrier options. Opioid use disorder should be viewed within a larger societal framework that is shaped by inequities in the social determinants of health. Where appropriate, clinicians should aim to address disparities in the socioeconomic detriments of health by connecting people with resources that meet these needs, such as housing, food, nutrition, financial assistance, and employment. Clinicians should also make a meaningful commitment to providing culturally safe care and practicing cultural humility in order to establish safe and positive partnerships with Indigenous peoples, families, and communities. Confronting and interrogating racist structures in healthcare and building awareness of one's own position with oppressive systems can help improve care and engagement and health outcomes for communities facing racism. Clinicians should be familiar with and incorporate the principles of trauma and violence-informed practice in the care and clinical management of people with OUD, with the goal of creating a safe and respectful environment that minimizes the potential for harm and re-traumatization. Clinicians should validate individuals' goals in OUD treatment and care, which may include recovery and/or self-defined wellness. A harm reduction-oriented approach to OUD care involves the acknowledgement and support of any steps taken by individuals to improve their health and well-being. Clinicians respect individuals' decisions and goals concerning substance use and promote strategies to minimize opioid-related harms. Opioid use disorder is understood to be a chronic, relapsing, and remitting condition. This guideline supports the use of a stepped and integrated approach in which treatment options are continually adjusted to meet the changing needs, circumstances, and goals of people receiving care. Opioid use disorder should be managed within a broader framework of comprehensive health care and support, including routine and ongoing medical, mental health, and psychosocial assessments. And last, family and social circle involvement in treatment planning and decision-making should be encouraged whenever possible and when deemed appropriate by the individual in their care team. I'll pass it off to you, Dr. Paxton.
Thanks, Karen, and thanks for the introduction to the guidelines. So for those of you who haven't met me, my name is Locke. I am calling in from the traditional unceded territories of the Coast Salish people, including the Musqueam, Squamish, and Tsleil-Waututh nations. I'm very grateful to be here today. And I'm happy to talk about these guidelines. I am a physician at St. Louis Hospital, one of the internal medicine, addiction medicine docs there. I also wear a few hats with BCCSU and it was my honor to be one of the co-chairs in this committee along with Ruby Brower and Emma Garrett. And I just want to recognize all the work that they and the rest of the committee put into this. I'm here today to run through the specific guideline recommendations somewhat quickly. There's a lot. This is a 200-page document, and obviously we want to focus on the really considerations today. So I'll try and take the back seat as much as possible, but we do want to go through some of the kind of core recommendations that inform a lot of the clinical guidance that Karen will then explore with you later in the talk. So I will go through those with everyone right now at rapid speed. So these are the 13 main guideline recommendations. Again, these are distinct from sort of some of the clinical recommendations that are explored in greater detail in our appendices. These are our core recommendations. Just for background, I think it's important to recognize how we came to this. Again, the last guidelines we had were from 2017. So these guidelines were put together by a group of experts from around the province. We had 30 experts from a variety of backgrounds and a variety of geographic locations who reviewed our previous guidelines and updated accordingly, and came up with these 13 recommendations that were graded using what's called the grade scoring process, which is a really transparent and traditional comprehensive way of scoring the strength of evidence behind guideline recommendations. So I'll go through some of the grade scoring with everyone right now. As you can see, most of these speak to pharmacologic treatment specifically. That's where we're able to provide kind of the highest level of detail. There are several that speak to non-pharmacologic treatment, and harm reduction has its own guideline recommendation. So go to number one. So the first, I'm seeing a chat. Jenny's having, is everyone able to hear me okay? Is that just you, Jenny, or is my audio poor?
Yeah, it's getting better now. It was just at first I was a little echoey or something like that.
Okay.
But yeah, you sound fine now.
Okay. Let me know if anyone's struggling. Guideline number one to start things off is speaking to pharmacologic treatment, and this is just stating that adults with opioid use disorder should be offered opioid agonist treatment as the standard of care. It's pretty straightforward, pretty non-controversial, high quality of evidence, strong recommendation, consistent with our previous guidelines and standard of care pretty much across North America. Not much more to say. Our OAT is life-saving treatment, and everything else should build off of it. Number two, a prescriber should work with each patient to determine which of the following OAT medications, including buprenorphine, methadone, or slow-release morphine, is most appropriate based on the patient's circumstances, their goals, and their previous treatment experiences. So this is a departure from how things were framed in the previous guidelines, where we had first and second and third line treatment. To be clear, this isn't to say that the evidence supporting the efficacy or safety of these medications is equivalent. They are different medications with their own profiles, but simply it's just about finding the medication that is most appropriate for an individual as quickly as possible, using a collaborative process to do so. The quality of evidence supporting this recommendation is high for buprenorphine and methadone. It's moderate for slow-release morphine, acknowledging that the evidence we have supporting the safety and efficacy of SROM is far less than the other two. But the strength of the recommendation remains strong. So this is new, and this is really intended on making these guidelines more patient-centered, and again finding the appropriate medication for somebody as quickly as possible. Recommendation number three, it builds off of the previous one, and it's simply stating that transitions between the different formulations of OAT should be facilitated if they're indicated by clinical circumstances, so side effects or intolerances or lack of efficacy, or if by patient preference, I want to try something different. The quality of evidence behind this recommendation is low, as this is it's not something that is necessarily well supported in literature, but the strength of the recommendation remains strong. Again, emphasizing that the importance of collaborative decision making, working with a patient to find and remain on the medication that suits their needs best in that moment in time. Recommendation number 4, so this is novel. So patients who are stable on between 8 to 24 milligrams of sublingual buprenorphine, naloxone may be offered the monthly extended release formulation, also known as Sublocade, if indicated by patient preference or circumstances. So this is a new recommendation simply because Sublocade was not approved in Canada in 2017. So this is a new addition to our guideline. The quality of evidence is low. There's some good data on Sublocade that's emerging, but it's still obviously a very new treatment option. The strength of recommendations is still considered strong. Recommendation number 5, I should also say that Sublocade, I think, has a particular relevance in rural remote settings because it really helps with in those who don't have immediate pharmacy access. So I hope that it's something that is being used in remote settings and people are finding success with. Recommendation number 5 may be a little bit less relevant in rural remote settings because of logistical demands. But injectable OAT with diacetylmorphine or hydromorphine should be considered with adults with severe OUD and ongoing unregulated injection opioid use who have not benefited from or who have declined oral options. The quality of evidence for this is moderate. There's again good evidence supporting the benefit of IOT. But the strength of recommendation here is weak and or conditional, given that there are logistical considerations that obviously weigh in. That being said, that's not an excuse to not be able to offer guideline-based treatment to people just because they happen to live in a more remote setting. So there's work for us to do to ensure that all British Columbians have access to evidence-based care. I should also say that this is a new recommendation because I previously was in its own guideline. It wasn't incorporated. It had its own guideline and its own set of rules. And this is just recognizing that I belongs in the continuum of care of evidence-based care for those with opioid use disorder. Recommendation number 6, OAT should be viewed as an open-ended treatment. However, if a patient doesn't wish to discontinue a medication following a sustained period of stability on OAT, which is recommended to be a minimum of 12 months or more, a slow taper should be offered rather than crash tapers or quick reductions or quick tapers off of the medication. The quality of evidence supporting this statement is moderate. Quick tapers, no matter how long somebody's been on medication for, quick tapers are associated with a much higher risk of relapse and other consequences. And the strength of this recommendation is strong. Recommendation number 7, for adults who do choose to discontinue OAT, a relapse prevention plan should be collaboratively developed and implemented after discussion of both pharmacologic and non-pharmacologic options. So this builds off the previous recommendation that OAT is meant to be a longer term treatment. But if somebody does want to discontinue at any point in time, that we do so in a safe and thoughtful way. We be slow and deliberate in the way we are tapering off, and once you are tapered off, that relapse prevention plans are in place. The quality of evidence supporting this is low. It's not something that is well demonstrated in the literature, but the strength of the recommendation is strong. This may include options including things like pill and pocket, Suboxone, or even oral naltrexone. So on that note, recommendation number 8, oral naltrexone is not a recommended treatment for adults with opioid use disorder. However, for those who have declined OAT or discontinued OAT and would prefer non-opioid treatment, it is recommended as preferable to nothing. The quality of evidence supporting it is low. The data supporting the use of oral naltrexone for the treatment of OUD in all comers is not particularly compelling, and the strength of this recommendation is weak. But it is an agent which may have a role to play for some people and should be used thoughtfully. Recommendation number 9, extended release naltrexone is not currently available in Canada, but it is an evidence-based treatment that may be considered for patients with OUD who are not interested in OAT. This is, I think, important for us to include here because this is a tool that does, I think, play a role in the management of opioid use disorder, recognizing it's not available anywhere in Canada. So this is as much of a call for advocacy as anything because it's not available to any of us. quality of evidence is moderate, supporting extended release naltrexone or Vivitrol for the treatment of OUD, and the strength of this recommendation is weak because it is unfortunately unavailable. Recommendation number 10, withdrawal management alone, including rapid OAT tapers without a transition to long-term OAT is not recommended. The quality of evidence supporting the dangers associated with this approach is moderate. Withdrawal management for opioid use disorder or rapid OAT tapers are associated with very high rate of relapse, loss of tolerance, and high risk of overdose death. The strength of this recommendation is strong. And again, building off of that for recommendation number 11, if the patient does choose to pursue withdrawal management, this should be conducted in an outpatient setting, not in a detox or a hospital, followed by a collaboratively developed relapse prevention plan and referral to long-term psychosocial treatment and support, so wraparound care, and really should be done as slowly as tolerated. The quality of evidence supporting this statement is moderate, and the strength of this recommendation is strong. Again, just to reiterate, rapid tapers off of OAT or detox from opioids without ongoing treatment with OAT is not recommended. If somebody does pursue it, it's not recommended to be done in an inpatient setting. It's meant to be done in an outpatient setting, alongside development of a relapse prevention plan and wraparound supports. Recommendation number 12, the last of our non-pharmacologic recommendations, psychosocial treatment interventions and supports should be routinely offered to adults with opioid use disorder in conjunction with pharmacologic treatment. The variety of psychosocial treatments is obviously wide. The evidence behind some of the more common ones is explored in the guideline itself, and I won't get into that today. And obviously, this recommendation very much depends on local resources. The quality of evidence of the statement is moderate, and the strength of recommendation remains strong. And lastly, a final recommendation, conversations about safer drug use, take-home naloxone, and referral to other harm reduction services should be routinely offered as a part of the standard of care for any individual with an opioid use disorder at any clinical encounter. The quality of evidence behind this recommendation moderate, and the strength of the recommendation strong.
So the next bit, we're going to take a closer look at the clinical guidelines, the clinical guidance. Did you have something else to say, Dr. Paxton? Okay. So buprenorphine naloxone, otherwise known as Suboxone, in the updated guideline, the maximum daily dose was raised from 24 milligrams to 32 milligrams. A daily dose of up to 32 milligrams of buprenorphine, 8 milligrams naloxone may be reasonable and can be provided safely to address the high opioid tolerance of people who use fentanyl. The day one maximum dose for traditional induction has been raised to 16 milligram buprenorphine. However, the higher doses can be used if withdrawal symptoms persist at 16 milligrams buprenorphine, 4 milligrams naloxone. Low dose induction, also referred to as microdosing induction or microinduction, is an induction method that slowly up titrates small doses of buprenorphine naloxone without cessation of all other opioids until a therapeutic dose has been reached. This may be the preferred induction method for people currently using fentanyl or other immediate and long-acting opioids. Take-home dosing prescribed using a blister pack has been quite helpful in our remote and rural communities, along with frequent check-ins. Next slide. So this is a 7-day low dose induction sample. The 8-day example protocol in the guideline may be preferable for some individuals due to consistent twice daily dosing during the induction. The benefits of a low dose induction: it doesn't require a period of withdrawal. It may reduce the risk of precipitated withdrawal. It can be started at home or at a clinic, and it can be co-prescribed with a full agonist to reduce reliance on unregulated drug supply during induction, which is also included in the certified nurse prescriber scope. Next slide. The traditional induction to prevent precipitated withdrawal. The adequate time since last opioid use is 12 hours or more for short-acting opioids if a person's using heroin, oxycodone, or hydromorphone. If a person is using slow-release oral morphine or confirmed or suspected fentanyl, the period of time to wait for the traditional induction is at least 24 hours or more. And if a person's on methadone, you would wait 48 to 72 hours. Precipitated withdrawal can occur when the first dose of the partial opioid agonist, buprenorphine naloxone, is administered to a person who has been using full agonist opioids, such as heroin, fentanyl, and oxycodone, before they have achieved a moderate stage of opioid withdrawal. 2 new options for managing precipitated withdrawal are introduced in option 3 and 4. Originally, the options included that we continue the induction with 2 milligrams buprenorphine every 1 to 2 hours until withdrawal symptoms are resolved. And the other option was to just stop the induction, provide reassurance that symptoms will resolve as the buprenorphine dissociates from the mu opioid receptors and the full agonist can resume its activity. In both these cases, we would offer non-opioid adjuncts and or short-acting not in option 1, but the second option, we'd offer short-acting full opioid receptor agonists to treat withdrawal symptoms as needed, and then offer to discuss a plan to future induction attempt or an alternate form of OAT. The new options are to delay the induction. If a person chooses to continue, consider waiting a few hours to allow full agonists to clear opioid receptors before administering the next buprenorphine naloxone dose. Offer non-opioid adjuncts to treat withdrawal symptoms as needed, continue up to the day 1 maximum or until withdrawal symptoms are resolved. And option 4 is high-dose buprenorphine naloxone induction. This involves treating precipitated withdrawal with an additional dose of buprenorphine naloxone in close succession, typically ranging from 8 milligrams to 24 milligrams in total. The non-opioid adjuncts to treat withdrawal symptoms to be considered include clonidine tablets, oral antiemetics, antidiarrheals, NSAIDs, and acetaminophen. There are different missed dose protocols for buprenorphine naloxone, depending on if the person has returned to full agonist opioid use or not, and how many days they have missed taking buprenorphine naloxone. 1 to 3 consecutive once daily missed doses with return to full opioid agonist use, there'll be no change in dose. It is likely safe to continue without reinduction. If there's 4 consecutive once daily missed doses with return to full opioid agonist use, clinicians should discuss the risk of precipitated withdrawal with the patients and weigh them against the benefits of continuing. For patients who prefer to continue, provide a buprenorphine naloxone test dose and discuss a plan for managing precipitated withdrawal. If 5 or more consecutive once daily missed doses occur with return to full opioid agonist use, a new induction may be required. Follow low dose or traditional induction protocols. Key practice change for pharmacists. The dispensing pharmacy is required to cancel the prescription if the individual misses 4 consecutive doses of buprenorphine naloxone with return to full opioid agonist use, and then notify the prescribing clinician. For missed doses without return to full agonist opioid use, 5 or fewer consecutive once daily missed doses will result in no change in dose. Resume previous dose without dose reduction. If 6 or more consecutive once daily missed doses occurs without return to full agonist opioid use, it does require retitration. So buprenorphine naloxone should be held pending virtual or in-person assessment, and the remainder of the prescription should be canceled. Reasons for missed doses should be discussed and documented during the subsequent clinical visit with attention to supporting the patient for better OAT retention. The retitration process should be individually tailored. The goal is to retitrate to previous stable dose within a few days. Key practice change for pharmacists. The dispensing pharmacy is required to cancel the prescription if the individual misses 6 consecutive days of buprenorphine naloxone without return to full opioid agonist use, and then notify the prescribing clinician. Extended release buprenorphine is a new addition to the guideline, otherwise known as Sublocade. Since the formulation became available after the release of the 2017 guideline, it is an extended release formulation of buprenorphine that is administered monthly via abdominal subcutaneous injection. It is quite popular, I find, in the smaller towns. It took a little while to catch on, but as there's been success with different people, more and more people are interested in trying this. Individuals should generally be inducted and stabilized on sublingual buprenorphine naloxone between 8 and 24 milligrams for a minimum of 7 days prior to receiving the extended release buprenorphine. Emerging evidence supports the feasibility of a more rapid transition to extended release buprenorphine, which may facilitate treatment retention. Individuals starting extended release buprenorphine should be prescribed 300 milligrams for the first 2 months, followed by a maintenance dose of 100 milligrams from the 3rd month onwards. At the discretion of The treating prescriber, the maintenance dose may be increased to 300 milligrams a month if the patient experiences ongoing opioid craving or ongoing unrelated opioid use. Individuals who have been on a stable 8 to 18 milligram of Suboxone can transition to 100 milligram maintenance after a single 300 milligram dose. Extended release buprenorphine doses must be administered monthly with a minimum length of 26 days is required between doses. So missed dose protocol with the Sublocade. Occasional delays of up to 2 weeks are not expected to significantly impact the treatment effect. If a person misses a monthly extended release buprenorphine injection, they should receive their next dose as soon as possible, and monthly injections should be resumed thereafter. If it's been more than 2 weeks, the reinduction may be warranted. Individuals should be restarted on sublingual buprenorphine naloxone, followed by a rapid transition to the extended release buprenorphine. Next slide. This guideline features adjusted guidance for methadone to allow higher starting doses for patients with higher opioid tolerance. So the starting dose will depend on multiple factors: the individual's known opioid tolerance, current opioid use, co-occurring substance use patterns. So the starting doses for those with low to no tolerance is suggested between 5 to 10 milligrams. For those with unknown or moderate known tolerance, the suggested starting dose is 10 to 20 milligrams. For those with known high tolerance, the suggested starting dose is 20 to 30 milligrams. And for those with known very high tolerance, the suggested starting dose is 30 to 40 milligrams. This guideline endorses a starting dose of up to 40 milligrams for individuals who use fentanyl and have previous experience with methadone. And to note, RN, RPN certified practice clinicians are now able to initiate methadone following these guidelines.
Can I just add something really quick there?
Yeah.
So what I'm seeing here in Quesnel is, and I hear from other advocates that do this work around BC, and I'm on methadone myself. So back in the heroin days, that's when I started, and 30 mil dose didn't really affect me at all. It would take the edge off. But now with fentanyl, I mean, I see people who are on 200 milligrams of methadone, 14 oxycontins a day, and it doesn't even get them on sick because the fentanyl is so much stronger. I was actually really disappointed when we were doing the guideline updates with the peers involvement. Really disappointed to see that the high tolerance and the very high tolerance starting doses were only 30 to 40 mils. We lose so many people when they're trying to get inducted on getting higher on their dose. It just takes so long. So that was one disappointment, actually.
If I can speak to that really quickly, Jenny, because I think it's such an important point. I completely agree with you. I'm in this unenviable position of chairing the guidelines that made that recommendation and also being frustrated by it. I'm very aware that it is not sufficient for so many of our patients right now. I work in the NME side, and so many of my patients are hard to retain. The challenge is that we have to make sure that this is, as a guideline, it's evidence-based and that we can stand behind the safety of it. And there's unfortunately no literature out there anywhere speaking to exactly what you're highlighting. So this is an area that I'm really advocating for more work to be done in, because I think we're really, really failing our patients, not being able to demonstrate that nuance in starting these medications. This is unfortunately kind of where we are right now, but I agree with you, we need to do better.
That's great. And maybe I can push BCCSU to do some research around this or something so we can make that change.
That's me, and it's one of my main research agendas right now.
Wonderful. Thank you so much.
100%.
On a positive note with the methadone is that they have increased the dosing titration, so how we move up on it. So for people with established high opioid tolerance and experience with methadone, doses may be titrated by a maximum of 15 milligrams every 3 days. Once the daily dose reaches approximately 85 milligrams, the titration process should be slowed to a maximum of 10 milligrams every 3 to 5 days. For people with lower unknown tolerance or no active fentanyl use, or those who have no history of OAT with methadone, doses should be increased more cautiously. For example, 5 to 10 milligrams, but still every 3 to 5 days. The optimal therapeutic dose varies widely among individuals. Previously, the range was between 60 milligrams and 120 milligrams. Current clinical experience suggests that doses of 150 milligrams or higher may be required to meet therapeutic goals in some individuals due to the higher fentanyl tolerance. And next slide, if there's no comments. So the new guidance also suggests higher SROM, slow release oral morphine starting doses for patients with higher opioid tolerance. The starting dose range is 50 to 300 milligrams. So again, for those with low to no tolerance, the suggested starting dose is 50. For those with unknown, moderate, known tolerance, the suggested starting dose is 100 to 150. For those with known high tolerance, the suggested starting dose is 200 milligrams. For those with known very high tolerance, the suggested starting dose is 300 milligrams. A starting dose of up to 300 milligrams for individuals who use fentanyl and have previous experience with SROM. Higher doses may be considered with caution on a case-by-case assessment of risks and benefits. Rationale for higher doses should be documented and individuals' informed consent should be obtained. And again, a note, RN and RPN certified practice clinicians are now able to initiate SROM following these guidelines. Next slide. So the dosing and titration of SROM, the dose increases up to 100 milligrams every 24 to 48 hours. The increase should generally be separated by at least 24 hours. There's no defined maximum dose for SROM. Key practice change, the default at the pharmacy will be to provide SROM as a whole capsule for the person to swallow whole. Prescribers do not need to specify this any longer on prescriptions. If it's clinically indicated, though, however, or preferred by a person that they wish the capsule to be opened and the pellets sprinkled into a cup for immediate ingestion, this should be indicated by the prescriber on the prescription. The new guideline has modified missed dose protocols to minimize unnecessary dose reductions that may disrupt treatment and affect treatment retention. In line with the new guidance, the dispensing pharmacy is required to cancel the prescription if the patient misses 4 consecutive once daily doses of methadone and SROM, and then notify the prescribing clinician. So within the new protocol, 1 to 3 consecutive missed days for both methadone and SROM, the dose remains unchanged. This means on the 4th day since the last dose, the person can receive their full dose. If there's 4 missing consecutive once daily doses, it does require a dose reduction. So for methadone, cancel the prescription, reassess, and restart at 50% or 30 to 40 milligrams, whichever is higher. And for SROM, cancel the prescription, reassess, and restart at 50% of the previous dose or the initiation dose, whichever is higher. 5 or more days, cancel the prescription, reassess, restart the titration. This means on the 6th day since the last dose, the person must restart their titration following assessment by the prescriber. It's noted here to use individualized assessment and clinical judgment for people receiving split doses or twice daily or more frequently. Count fully missed days according to the missed dose protocol. Dose reductions may be considered based on individualized assessment of tolerance, loss, and associated risks. Take-home dosing of buprenorphine naloxone or Suboxone should be considered immediately, including during induction, where clinically indicated for all people who meet the following criteria of clinical and psychosocial stability: the ability to attend appointments, the absence of unstable psychiatric comorbidities such as psychosis or suicidality, absence of severe behavioral issues at the clinic, absence of severe sedation, absence of high risk or uncontrolled substance use patterns that cause frequent overdoses or blackouts, and the ability to safely store medication. It can be initially prescribed as a 1 to 2 week supply to establish the effectiveness of dosage. Longer prescription intervals may be appropriate once stable dose has been established. People experiencing homelessness can be considered for take-home dosing, and people who continue to use substances can also be considered for take-home dosing. Take-home dosing promotes feelings of trust to self-manage, which supports stability, quality of life, retention, and overall agency. This ability to self-govern medication administration makes it possible for clients to take their medication at a time suited to their needs and or split doses, ultimately improving sleep and management of cravings. This also reduces stigma of supervised dosing and facilitates a life treatment balance at home. Some people still prefer the routine of attending the pharmacy, as it may give them a reason to get out of the house. Just be open to both, I think, is very important. Next slide. So take-home dosing for methadone and SROM. There is alignment with the take-home dosing criteria for both methadone and SROM. Total cessation of non-prescribed substance use is not required. Take-home methadone and SROM doses should start as individual non-consecutive doses for individuals who meet the take-home dosing criteria. Additional take-home doses can be offered gradually every 2 weeks to individuals who consistently manage previous take-home doses, sustain medication adherence, experience improving clinical and psychosocial stability. Clinical discretion may dictate faster take-home dosing schedules in rural regions, pharmacy hours, previous succession with take-home doses, and work schedules. The updated guideline has relaxed the criteria for take-home dosing for full agonist medications to allow gradually increased take-home dosing starting at 4 weeks of treatment for people who are stable on their medication and are able to store their medication safely. The following criteria is aligned for both methadone and SROM. So clients are not considered a candidate if they're unable to safely store medication, if they're unstable psychiatric illness or other acute mental health crisis, if there's frequent missed doses and appointments, or if there's ongoing high risk or uncontrolled substance use patterns. Otherwise, at a minimum 4 weeks of medication stability, doses can be prescribed with 1 to 3 non-consecutive take-home doses if clients can store their medication safely and have clinical and psychosocial stability, such as the ability to keep appointments, manage medication, no acute behavior or psychiatric issues, no high risk or uncontrolled substance use patterns that cause frequent drug poisoning, blackouts, or other severe safety risks. After 12 weeks of medication stability, doses may be prescribed with 4 to 6 consecutive take-home doses if clients can consistently adhere to medication with rare missed doses and appropriate management of non-consecutive take-home doses. Improved clinical and psychosocial stability, including rare missed appointments, minimal unprescribed substance use in alignment with the treatment plan and patient goals, with no recent drug poisonings or blackouts. Potential ability to receive caries earlier based on clinical and psychosocial stability, urine drug test results, and ability to safely store medication is discussed in individual cases. This is just reiterating the previous slide, so we can just skip it. So with urine drug testing, there's actually been some changes here in the guideline. The urine drug testing guidance has been aligned with the BCCSU's urine drug testing in patients prescribed opioid agonist treatment and emphasizes person-centered and collaborative care. Key changes are urine drug testing should be performed when the results may impact the treatment plan. They should not be used punitively or when results will not impact treatment. There are no minimum number of required urine drug tests for individuals on OAT. The purpose of urine drug tests should be discussed with individuals, including how unexpected results will be addressed. Confirmatory testing should only be ordered when results would change clinical management. Urine drug tests should be scheduled instead of random. Urine samples should be collected using supervised urine drug test procedure in clinical settings. Witnessed urine drug testing is not appropriate and can be harmful. A negative urine drug test for other opioids or substances is not required to be considered for take-home dosing. A positive urine drug test for other opioids or substances alone is not grounds for discontinuation of take-home dosing, switching back to daily witness, or discontinuing treatment. This updated clinical guidance contains information on concurrent mental health concerns, ongoing substance use, acute care and inpatient considerations, chronic pain, long-term effects of OAT, tapering OAT medications, and opioid agonist treatment and driving. Emergency department buprenorphine naloxone induction contains guidance on the initiation in emergency departments. And specific populations contains guidance for specific populations, including Indigenous peoples, 2S LGBTQ+ populations, pregnant individuals, youth, older adults, and rural and remote communities, and more. In summary, the key content in clinical updates focuses on the central principle of person-centered care. It moves away from ranking oat medication and moves towards an individually tailored process whereby clinicians discuss the risks and benefit of all 3 oral oat options with people receiving care and collaboratively select a medication that aligns with their preferences, treatment history, and other individual circumstances. Modified maximum starting dose and titration protocols for oat medication to address the needs of individuals with higher opioid tolerance, low dose induction guidance for buprenorphine and naloxone to eliminate the need for a period of withdrawal prior to medication initiation, guidance on the provision of monthly extended release buprenorphine as a least intensive, more flexible option for patients who are stable on sublingual buprenorphine naloxone, simplified guidance for addressing missed doses, less restrictive protocols for providing take-home doses of full agonist medications, and updated guidance on urine drug tests. Within the context of the rural and remote care, it's important to recognize limitations and barriers within the environment and the importance of being flexible, collaborating, and building relationships within communities. With the addition of the RN, RPN certified practice clinicians, there's significant value in shared care between doctors and nurses to meet the holistic needs within person-centered care and collaborate assessment and treatment for opioid use disorder. Thank you.
I just wanted to quickly just put a couple of comments in there before we move on, if that's okay. Do we have time for like a 2-minute spiel?
Jenny, I was just going to ask if we have any questions.
Sure.
But maybe what I can do, because we have about 9 minutes left, is we have one question in the chat from a guest, and then maybe leave space for 2 questions, and then we definitely have time for your spiel.
Okay, great. Thank you.
Okay, and so just this is just a question for the panel here, which also came up at the last session. So to the panel, one of the guests is wondering, what is considered high risk or uncontrolled substance use patterns in the context of take-home doses? Are there any objective criteria to help determine this?
I can speak to that a little bit, and then maybe others can chime in, because this is, I think, one of the most significant changes in these guidelines, one that I'm most excited about, and one that I can say has done collaboratively with folks from Ontario who have launched similar guidelines recently. The answer is sort of. So ultimately, you're right. So there is certainly more clinical discretion that is permitted or asked of our prescribers now around the determination of take-home doses. And one example would be determining what is high risk or uncontrolled substance use patterns. So there are some examples provided both in our guideline, and if you really want a really thorough document that kind of explores what this might look like, I would direct you towards Medify has put out a couple of documents discussing the same sort of approach. But examples might be the difference being somebody whose use has gone, if their use has gone from a gram a day to a point a day, they're using in the evening consistently to sleep, they're getting through the day, they're feeling well, and either they find that their doses wearing off in the evening or it's part of their habit. It's no longer compulsive, it's pretty controlled. Maybe it's not every day, it's intermittently. Maybe it's not opioids, maybe it's some cocaine use here and there or something like that. Those would all, to me, sound like characteristics of ongoing use, but certainly not uncontrolled. Whereas if somebody's still using, a half gram to a gram a day, using daily throughout the day, still experiencing significant withdrawal, having compulsive use and sort of a lack of control over the use, that's somebody who may not be as appropriate at this time for take-home doses of methadone until you get them to a dose of methadone where you and they together feel like their use is controlled. And it's still a staged process. So you're starting with one day and seeing how that goes, seeing how they're finding it and how things progress from there. So it's still iterative. But you're right, is that it does ultimately depend on your clinical judgment much more than previous guidance.
I think I'll just add in too, like the point about frequent drug poisoning, blackouts, or safety risks. is one of the considerations that I would look at. And then how a person is in their family and their home life, how stable are they in order to maintain work, or what are their relationships like? If somebody is using uncontrolled substance use, they might have some lack of stability in other areas of their life. And so we want to help support them in maintaining stability in all those areas, and they're going to have more success in their recovery.
Yeah, great points from both of
Yeah,
you.
that's a really other good example. So presentations to hospital overdoses, also examples of unstable use.
Okay, and we have one more question. Can you please share why naltrexone is contraindicated? This phrase is a little funny, so I might not get this right in how they intended it, but they said, why is naltrexone contraindicated when OAT was discontinued? Does that make sense to you?
I think that may be a misunderstanding. So naltrexone's contrary is not indicated as a form of opioid agonist therapy. It's not recommended. Oral naltrexone, that is specifically. But as a part of a relapse prevention strategy for somebody who's either chosen to taper off of their OAT or is not interested in their OAT, then oral naltrexone is recommended as essentially better than nothing. But to be clear, the evidence for oral naltrexone is really poor. And it's not held up as at all equivalent to agonist therapy, which remains gold standard of care.
Thanks for clarifying, Paxton. Okay, I'm going to hand it over to Jenny so that you can have your spiel. And I'll also just put a shout out to, again, please answer our post-webinar poll. It's really important for us in measuring how well we did today and sharing this information with you. And we're always looking for your feedback so we can make our education better for you. So thank you, and I'll hand over to Jenny.
Thank you so much. Yeah, I just wanted to chime in, and I have about 20 years of experience on and off OAT. And now the work that I do out of CSUN, we have a program called the PAP program, Prescription Alternative and Advocacy Program. And I started doing this during COVID. We started doing the medication deliveries. So I deliver to our homeless population, to our supportive housing building, our shelter, and the hotels where people live through the BC Housing Rent Program. And I can tell you, having a peer do this has helped so many people be able to maintain on their meds. Like, I don't just go there once a day, and then if they're not there, return the meds. I'll go back a few times. They can come to my house till about 7 at night if they're not at home that day. They give me permission to look for them in certain areas, so I know where to find people. And also I can give them reminders at the beginning of the week and the day before and the morning of their appointments. I give them rides to their appointments. And again, it's not just the OAT and state supply meds. We look after the whole person. So where I know healthcare professionals are very busy, they don't have time to do all the extra stuff. We don't have time to do all that extra, nurses don't have time to do all that extra stuff. When you're working with peers, we can do the extra stuff that you might not be able to do under your role. We can go and do outreach, we can bring people to meet you, and all this other stuff. So it just works so well with that working with the people with lived experience. We bridge that gap quite well to the healthcare professionals.
That's excellent, Jenny. And, it's a good example too of just the innovation that can take place in these remote and rural areas, and just working together as a community and healthcare professionals, we can make a big difference.
Absolutely. Thanks so much, Jenny and Karen. And I just want to say a big thank you to the panel, and also my apologies, Paxton, thank you for acknowledging all the work of the co-chairs of the OUD Guideline and the members of the Guideline Committee. We obviously could not have done this without you, and this guideline's fantastic, and really appreciate you noting that in your introduction. So thank you everyone for being a part of this webinar. Please complete the post-webinar survey. We really do value your input, and just thank you. A big round of applause to the panelists for sharing your expertise today. It's great to work with all of you, and I hope you all have a wonderful afternoon. Panelists, if you have time, please stay after the session for a 5-minute debrief, and if you can't, thank you again for being here.